Thank you, sir, for giving me this chance of speaking in your instruction course. What I'll be talking is approach to epiretinal membrane and macular hole. I think I'll have to stop share and share again. Sir, ये आगे नहीं बढ़ रही है.
I think you have to.
No, I think the host sometimes is shutting down the video. I had that problem. So
Also had it.
could you please enable Dr. Avnindra? We are seeing your screen,
Yeah,
Dr.
now it's okay.
Okay.
ERM was first described by Ivanov in 1865. 2% of the patient above the age of 50 and 20% of the patient by 70 years get affected by epiretinal membrane. Bilateral involvement occurs in 10 to 20% of the patient. Beaver Dam study, which was an OCT-based study, showed prevalence as high as 34.1%. In 2016, the preferred practice guidelines for epiretinal membrane over a period of 5 years showed 29% of the ERM progressed, 26% regressed, and 39% remained stable. So what we see is only 1/3 of the patient will require surgery and 2/3 of the patient will not require surgery. So don't jump over surgery once you see ERM. Follow this patient for at least 3 to 6 months and see whether they are stable or progressing. Coming to the causes of ERM, usually it is idiopathic. Clinical features, usually it is asymptomatic. 5% will have vision of less than 660, reduction in vision, and metamorphopsia is the major complaint in advanced epiretinal membrane. You will have mild sheen, what you see here, and there will be a vascular tortuosity. The arcades will be straightened. The vessels are straightening. In advanced cases, there will be a stria and heterotrophy of the macula, intraretinal hemorrhages, and cystic changes in the macula. OCT is the best diagnostic tool to diagnose epiretinal membrane. FA shows leakage in the late phase. Coming to the treatment part, asymptomatic ARM with good vision, no treatment is required. Symptomatic ERM, that is vision, is less than 624. The patient is complaining of metamorphopsia. If the ERM is thick, then it requires pars plana vitrectomy with epiretinal membrane. If you can document there is a sequential decrease in vision, that patient is eligible for surgery. Now, this is one of the patient. You can see on OCT, there is a loss of foveal contour and a thick epiretinal membrane, altering the shape of the retina. We took this patient for surgery. And first the vitrectomy is done. You can see a thick epiretinal membrane covering the foveal area. It's important in the epiretinal membrane surgery to create an edge, and how we create this edge is with 25 gauge MVR blade. So once the edge of the epiretinal membrane is created, half of the surgery is done. This is the most difficult part of the surgery. And once the edge is created, you take an Eckhart forceps and start peeling the membrane. The traction, what you put on the membrane should not be anterior, posterior. It should be a tangential traction. Many a times you don't know the extent of the epiretinal membrane, so you need to put dye. In this case, I have used BBG dye, and I can see delineate the membrane, and then I pick up this membrane and gradually peel it tangentially. You can
Sir,
see.
with all due respect, sir, the time for this session is over. So I would request you to please sum up within the next 2 minutes, as we have another session to start at 2 o'clock.
Okay. So what
Thank
you
you,
can
sir.
see, I'm removing the membrane here, and the membrane is removed in total. Post-operative picture, you can see here the foveal contour has returned back, and the patient improves to 618. This is another patient post VR surgery, and What we have done, we do a fluid air exchange, and many times you are not able to see. We put a reti blue dye. This helps us to delineate the extent of epiretinal membrane. And once the edge is created, then you catch hold of the epiretinal membrane with the help of the Eckhart forceps and pull it uh, gently and tangentially, and whole of the membrane comes in one go. Improvement in visual acuity occurs by 2 lines in 74%. No improvement occurs in 24% of the patient. There is a controversy whether you should remove the ileum along with epiretinal membrane. Liu et al. Performed a meta-analysis of ERM surgery with and without ileum peeling. Patient who underwent ileum peeling had better visual acuity at 12 months. By 18 months, no significant difference in both the groups. Microperimetry showed better results in non-ileum peeling eye. I won't go to the prognostic factors.
Yeah, you can come to macular hole surgery.
Yeah. Coming to the treatment of macular hole, medically, it can close spontaneously. Intravitreal oculoplasmin was tried, but the results are not very encouraging, and few patients had decrease in vision, and the cost was exorbitant. So intravitreal oculoplasmin is not being used. Macular hole can be classified less than 400 microns, 400 microns, and failed macular holes. And this is one of the patient, what you can see here. Uh, we have done a tricot staining and PVD was induced. This is a macular hole with an epiretinal membrane. Once you have put the BBG, you can see this whole area has not got stained with the BBG dye. So we know that there is an adjunct, there is an associated epiretinal membrane. So we use a diamond dusted to create an edge, and this epiretinal membrane is peeled. So once this epiretinal membrane is peeled, we do a restaining of this area, and you can see again whole of the ileum gets stained. You can see whole of the ileum gets stained here. So now we create an edge with the help of a diamond dusted, and we peel the membrane. Generally, depending on the size of the hole, we decide whether we have to go for an inverted technique or we have to go for an full no inverted technique. So in this case, I do an inverted technique and leave the flap adjacent to the macula, and then I enlarge the ileum peel. This is one of the cases of failed macular hole, and I have done this surgery, and you can see the size of the macular hole is 1785 microns. It's a huge, large macular hole which has failed, and we took this patient for surgery. And the vitrectomy was done, the BBG was put, and I was planning to do a bimanual surgery, so additional Sandier light is put. Once the BB is cleared, you can see the large ileum peel which I have done previously. So I initiate ileum peel, and once the ileum peel is initiated, I put a PFCL, because if I don't put a PFCL, this ileum will keep on
Sir, I would request
roaming.
you to please sum up, as it is already 2 and we need to start with the next session.
Okay. And this is one thing. What we did, we removed the PFCL, and simultaneously what we did, we injected colored visco to stabilize the ileum flap, and then with the help of a 40 gauge needle, we created a detachment to mobilize the retina, and you can see we have closed the hole. The vision improved to 624.
Okay, I think with this,
Yeah.
we thank all the speakers.